Now, Jamie Conti and Dr. Vera Bittner, Professor of Medicine and Director of Cardiac Rehabilitation at the University of Alabama at Birmingham, discuss a call to arms, efforts aimed to improve outcome through cardiac rehabilitation.
Welcome to ACCEL, Dr. Bittner.
Thank you very much.
As I understand it, you've been invited to talk here at the American Heart Association on cardiac rehabilitation, which is obviously your area of expertise. Let's start out with, how does rehabilitation help our patients sort of in broad categories?
Yeah, I think it's worthwhile defining cardiac rehabilitation to start with, because I think people still have this old model in mind where cardiac rehabilitation is purely exercise. And I think we should think of cardiac rehabilitation in these days as comprehensive secondary prevention. And so we address behavioral outcomes, we measure clinical outcomes such as A1C levels, lipid levels, things like that. We have quote-unquote data on heart health outcomes like morbidity and mortality, and then we also track utilization rates, patient satisfaction, and such.
As you say, people have sort of old-fashioned ideas about cardiac rehabilitation. In terms of outcomes, why should we be referring our patients for rehab?
I think the area where we get compared with other interventions are the heart health outcomes, i.e. morbidity and mortality. And we have data from two different spectrums of data sets. We have data from the older randomized controlled clinical trials, and we have more contemporaneous observational data, and both of them suggest that there's a significant mortality and morbidity benefit from attending cardiac rehabilitation in the range of about 20% mortality reduction and somewhere around 15% reduction in recurrent myocardial infarction.
Oh, that's impressive. So you mentioned myocardial infarction. Who should, aside from patients with coronary disease, who are the groups of patients who should be referred for cardiac rehabilitation?
Yeah, I think we need to distinguish between the groups that can benefit and the groups that will get insurance benefits to actually attend, because that is not completely synonymous. So Medicare, which is the largest insurance provider, will pay for basically any variant of coronary artery disease, post-CABG, post-PCI, stable angina, after myocardial infarction, and they will also reimburse for other open heart surgeries. To date, they have not decided to reimburse for heart failure, for example, where we have some evolving data that it would be beneficial. And the big area that has not been really tapped is the person with the multiple risk factors. So ideally, capturing people before they have the event, the person who's diabetic, hypertensive, dyslipidemic, overweight, sedentary, would presumably benefit. But it's very hard to get folks like that in the programs because of the lack of insurance reimbursement.
Yeah, that would make it tough. We were talking earlier before this recording, how does rehab compare to the other interventions that we routinely initiate in our patients, for example, beta blockade?
Yeah, there's a very interesting analysis from Earl Ford where he looked at mortality after a myocardial infarction in 1980 and in 2000. There were a little bit over 340,000 fewer deaths in 2000. And then he tried to apportion this decline in CHD mortality rate to the different interventions that have occurred during that time. And it turns out that the contribution of cardiac rehabilitation was on par with post-MI aspirin use, beta blocker, ACE inhibitor and such, and also on par with the acute revascularization, thrombolysis, PCI. So I think cardiac rehab compares quite favorably to some of the other things that we do much more routinely.
So interesting, but I'm sure our listeners are wondering, is that because the patient who can actually enter cardiac rehabilitation is well enough to exercise? Is there some sort of selection bias when we look at that information?
There's clearly a self-selection bias going on, because if you think about participation in rehab, it requires three things. You need to be referred, you actually need to actively enroll, and then you need to adhere to the regimen. So, I mean, some degree of selectivity is clearly there, but there was a very interesting analysis from Brandy Witt a few years back using the Olmsted County database, where she calculated or estimated the propensity of an individual to participate in cardiac rehabilitation and looked at the benefit as a function of this propensity to participate. And it turns out that the benefit is actually quite uniform across all quartiles of likelihood to enroll in a cardiac rehab program. And so maybe what we need to focus on is removing some of the barriers for the people who are not referred or choose not to enroll or don't adhere, and we might be able to increase the benefit of cardiac rehab even further.
So let's talk about that a little bit. What are the barriers to utilization?
Well, there's some kind of demographic predictors that go along with not enrolling in a cardiac rehab program. So older people tend to have more difficulty, A, because they don't get referred because people think of them too frail to participate, and then also practical things like they may not drive anymore and may not be as mobile and things like that. Generally, minorities underutilize cardiac rehabilitation. People with lower educational background, lower ACES tend to underutilize it. And so I think we need to focus some of our future research specifically on these groups and see whether we can come up with models that make it a little bit easier for them to participate and still have the same efficacy as the standard rehab.
Okay. What important take-home messages for our listeners? I know we touched on that there is a new guideline that's being developed or about to be published.
Well, it's actually not a guideline. There will be a scientific advisory statement from the American Heart Association specifically on the benefits and utilization of cardiac rehabilitation that will come out in the near future. So I think the need to make cardiac rehab more widely available and more used has been recognized by a number of medical societies, and so hopefully these low referral rates that we're currently seeing can be ameliorated in the future. Because when you look at cardiac rehab enrollment, for example, in the Medicare population, there's a 9-fold difference across the 50 states in referral enrollment rates to cardiac rehab programs, and so working to make a uniformly higher referral and enrollment rate should have a big payout down the road.
Do you think the difference in utilization has more to do with physicians not referring patients or with patients not enrolling, or it's a mix?
I think that there's a mix of barriers at the physician level, because there's an interesting analysis that actually one of my colleagues in my division did using the Get With the Guidelines data set, where he could show in Get With the Guidelines hospitals that these physicians who are clearly attuned to secondary prevention are much more likely to use the pharmacologic interventions like aspirin, beta blocker, and ACE inhibitor than to do the cardiac rehab referral. So there's clearly a barrier on the physician side, but I think there are also some system barriers, lack of insurance coverage, lack of transportation, things like that. And then there is a barrier at the patient level where I think most patients don't appreciate how much this program could benefit them. And so a lot of patient education might help that down the road as well.
So bottom line, we need to be referring our patients for cardiac rehab. It helps, and then we need to try to get them to adhere to the referral.
Yeah, and I think we need to kind of come up with some newer delivery models down the road as well, and hopefully have some flexibility among the insurance companies and policymakers to eventually reimburse for these alternate delivery methods, provided that they can show efficacy.
Great. Thanks for being on ACCEL, Dr. Bittner.
Thank you very much for the opportunity.